Good morning, everyone. So, today we are going to discuss the topic of neoplasia. So, neoplasia means occurrence of a new growth. This new growth is called neoplasm. So, neoplasia means occurrence of a neoplasm. Okay, and what is the study of tumors or neoplasms called? It is called oncology. The word is derived from the Greek word onkos, which means tumors. So neoplasia means occurrence of a neoplasm. But what is a neoplasm then? A neoplasm is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissues and persists in the same excessive manner after cessation of the stimuli which evoke the change. Now, this definition of a neoplasm by British oncologist Willis, it is the most accepted definition over the entire world. This is a definition which, if you have come to study pathology, you should definitely know the definition of neoplasm. Any examiner will ask it to you. So let's break it down. What this definition is saying: neoplasm is an abnormal mass of tissue. Okay, so there is a tissue mass which is not following normal parameters. It is not following normal rate of growth. It is not following the normal coordinated growth pattern compared to the rest of the tissues of the body, and it also persists in the same excessive manner after cessation of the stimuli which evoke the change. So there must have been an initiating stimuli which promoted this abnormal mass of tissue to become abnormal from normal, right? So this abnormal mass of tissue, it is said, it will continue to grow even after the stimuli which caused it to grow in the first place. Even if that stimuli is stopped, it will continue to grow in the same excessive and uncoordinated manner. So basically this is the definition of neoplasm. So what are the components of a tumor? First, let us understand what is parenchyma. Parenchyma of any organ is the functional tissue of an organ as distinguished from the connective and supporting tissue. So every organ has parenchymal tissue, connective tissue and supporting tissue. Okay, so a tumor's parenchyma, what is it? The proliferating tumor cells constitute the tumor's parenchyma. It determines the classification of tumors and their biological behavior. Also, reactive stroma, that is fibrous connective tissue and blood vessels within the tumor. The growth and spread of the tumor is critically dependent on the reactive stroma around it. Okay, so the parenchyma of the tumor, and the reactive stroma surrounding it, basically it determines what kind of spread this tumor will show, what kind of biological behavior it will show, and how it will be classified. What is the classification of tumors? Tumors can be benign, they can be malignant, or they can be mixed. Let us understand basically what these are. Benign tumor is said to be that which has a gross and microscopic appearance, considered relatively innocent, implying that it will remain localized, will not spread to other sites, and is amenable to local surgical removal. So basically a tumor which will stay in its place, will have well defined borders, therefore will be easily removable and will never spread to other distant sites. So this is a relatively safer kind of tumor. It is called a benign tumor. Okay, let us understand how these tumors are named. So basically nomenclature of tumors is a very simple affair. What we do is we take the name of the tumor, we take it based on the original tissue from which these cells are derived. Okay, and to that name we add the suffix oma. For example, a benign tumor arising from fibrous tissue is called a fibroma. A benign tumor arising from cartilaginous tissue is called a chondroma. A benign glandular tumor, that is tumor arising from epithelial tissue, is called adenoma. A benign bone tumor is called osteoma. On the other hand, if we consider malignant tumors, okay, malignant tumors are not innocent. They are very, very aggressive. They can invade and destroy adjacent structures, and they can spread to distant sites. All of these are opposite to the behavior of a benign tumor. Okay, Malignant ones are no longer innocent, they don't have any well defined border, they cannot be easily removed surgically because they are showing local invasion, and also they can spread to distant sites, a phenomenon which is called metastasis. So they can metastasize to other sites and cause death. So malignant tumors arising in solid mesenchymal tissues are usually called sarcomas. The word is derived from the Greek word sar, which means fleshy. So just like we named the benign tumors, we can also name the malignant tumors. Okay. So malignant tumor from the fibrous tissue, arising from the fibrous tissue, is called fibrosarcoma. Malignant tumor arising from cartilaginous tissue is called chondrosarcoma. Malignant bone tumor is called osteosarcoma, and malignant tumor of blood forming cells is called leukemia. Malignant neoplasm of epithelial cell origin is called carcinoma. What did we learn? The benign variant was, we learned that the benign variant was a adenoma, but its malignant counterpart is carcinoma. So squamous cell carcinoma is a neoplasm where tumor cells resemble stratified squamous epithelium. Adenocarcinoma is composed of neoplastic epithelial cells which grow in a glandular pattern. A cancer composed of cells of unknown tissue origin is called undifferentiated malignant tumor. Lastly, we have mixed tumors. So what basically happens in other benign and malignant tumors, the tumor parenchymal cells, they resemble one another, but whenever there is a divergent differentiation of a single neoplastic clone, it creates a mixed tumor. A prime example of this is pleomorphic adenoma, a tumor of salivary glands, wherein we can see the normal salivary gland of the tissue is there, but in the tumor mass we can see both mesenchymal component, that is pseudocartilage, but we can also see epithelial component, that is ducts, acini and tubule, and also these tumor cells can be seen in sheets and strands. Now we have another benign tumor, that is a teratoma. Okay, it contains recognizable mature or immature cells of tissues belonging to more than one germ cell layer, sometimes even 3, and the malignant counterpart of it will be called a teratocarcinoma. So here is a summary of the nomenclature of tumors. Let us look at it again. Okay, connective tissue and derivatives. Tumor arising from fibrous tissue, but benign variant is called fibroma. Its malignant counterpart is fibrosarcoma. Benign tumor of fatty tissue is lipoma, but its malignant counterpart is liposarcoma. Benign tumor of cartilaginous tissue is chondroma. Its malignant counterpart is chondrosarcoma. And osteoma, its malignant counterpart, osteogenic sarcoma. Similarly, benign tumors arising from smooth muscles are leiomyoma, and their malignant counterpart are leiomyosarcoma. Benign tumors arising from striated muscles are called rhabdomyoma, and their malignant counterpart is rhabdomyosarcoma. Okay, again we can see here the totipotental cells in gonads or in embryonic nests. We can see the benign tumors arising from these cells are called mature teratoma, whereas the malignant tumors arising from these cells are called immature teratoma or also teratocarcinoma. So what are the characteristics of these benign and malignant neoplasms which can help us differentiate them from each other? So basically, what are the differentiating features of benign and malignant neoplasms? These are rate of growth, cancer phenotype and stem cells, clinical and gross features, microscopic features, and the spread of these tumors, local invasion or direct spread, or metastasis or distant spread. So here is a summary of all the features which show the difference between a malignant and a benign tumor. Okay, we can see here that the clinical and gross features are again differentiated into the various headings of boundaries, surrounding tissue, size, secondary changes, and you can see very well all of these features are different for benign versus malignant tumors. So this slide shows the summary of it, but we'll have to dive deeper into them. So let us look at these features one by one. First is rate of growth. So basically, it depends on two main factors, that is rate of cell production, growth factors, and rate of cell loss. And last again, and secondly, we have the degree of differentiation of the tumor. Rate of cell production is basically the doubling time of tumor cells, number of cells remaining in proliferative pool, and rate of loss of tumor cells by cell shedding. And degree of differentiation means the poorly differentiated tumors versus well differentiated tumors. Poorly differentiated tumors show aggressive growth patterns as compared to better differentiated tumors. Some tumors, after a period of slow growth, may suddenly show spurt in their growth due to development of an aggressive clone of the malignant cells, and most probably this sudden spurt of growth will be a poorly differentiated growth. And these are the various growth factors responsible for tumor growth. This is simply something you have to memorize. Cancer phenotype and stem cells. Normally, there is a balance between the rate of cell proliferation and the rate of cell death. Whereas in cancer cells, the neoplastic cells, they disobey the growth controlling signals in the body and thus proliferate rapidly, and they escape death signals and achieve immortality. Therefore, this imbalance of cell proliferation and cell death leads to excessive growth. Due to loss of growth controls, cancer cells are genetically unstable and develop even newer mutations, and they have the ability to overrun their neighboring tissue and invade locally. They also have the ability to travel from the site of origin to other sites in the body, where they colonize and establish distant metastases, as I told earlier. So the tumor initiating cells, these are cancer cells, and these are clonal. These are cells which by clonal proliferation of a single progeny of a cell become a cancer cell, and these stem cells have the properties of prolonged self-renewal, asymmetric replication, and transdifferentiation. So basically, any progeny of a cell, if it starts showing clonal proliferation, it leads to a cancer cell, and these cells will show prolonged self-renewal. That means they will continue to renew themselves even after the initial growth factor stimulation is stopped, and also they will show asymmetric replication, okay, and also they will show transdifferentiation amongst each other. Then we have the clinical and the gross features. A benign tumor will be slow growing, asymptomatic, and or sometimes can produce serious symptoms, whereas a malignant tumor will definitely be rapidly growing, will definitely show invasion into surrounding tissue or metastasis. It may also ulcerate, it may lead to weight loss, anorexia, or even anemia. So gross appearance. Benign tumors will be grossly, they will appear as spherical or ovoid in shape. They will be encapsulated, well circumscribed, freely movable, not attached to surrounding structures, and they will not have secondary changes like hemorrhage or infarction. And if secondary changes like hemorrhage and infarction are there, then their appearance may not be very firm and uniform. Malignant tumors, on the other hand, they will definitely be irregular in shape, poorly circumscribed, and extend into the adjacent tissues. Secondary changes like hemorrhage, infarction, and ulceration will be definitely seen more often, whereas they may not be seen in our benign tumors. Microscopic features. Basically they will be discussed under the following headings: microscopic pattern, histomorphology of the neoplastic cell, that is differentiation and aplasia, tumor angiogenesis and stroma, and inflammatory reaction incited by the tumor. So microscopic pattern, let us consider epithelial tumors. Okay, they will generally have acini. The tumor cells can be arranged in sheets or columns or cords also, and they might be arranged in a solid or a papillary pattern. On the other hand, for mesenchymal tumors, the tumor cells may be arranged in interlacing bundles, fascicles, or whorls, and they will be separated from each other usually by the intercellular matrix substance. For example, leiomyoma will have hyaline material, chondroma will have cartilaginous matrix, and osteosarcoma will have osteoid. Also, we can see some mixed patterns, and in hematopoietic tumors such as leukemias and lymphomas, they will have little to no stromal support. Here is a picture showing us this difference. For example, in a benign tumor, we have a very well defined tumor, an encapsulated one with well defined borders, not very much adjacent to not very much attached to adjacent structures, freely movable, not showing any local invasion. On the other hand, we have a malignant tumor which is diffusely infiltrating on its borders, is not well circumscribed, very much adhering to the adjacent structures, and much larger than the benign tumor. Okay, much more aggressive looking. Then let us compare leiomyoma versus leiomyosarcoma. As we can see, the leiomyoma is having a well defined structure, well defined border, whereas the leiomyosarcoma is locally invasive, not having any well defined structure, and also showing some secondary features. And the benign tumor will show benign fibroblasts, also some high degree of hyaline change, whereas the malignant tumor will show hyperchromatic nucleus, pleomorphism, some tumor giant cells, and mitotic figures. Do not worry, we'll be discussing these words in the upcoming slides in detail. So, cytomorphology of neoplastic cells. Characteristic features of neoplasia are differentiation and anaplasia. What is differentiation? Differentiation refers to the extent to which neoplastic parenchyma cells resemble the corresponding normal parenchymal cells, both morphologically and functionally. So based on this, how well they resemble their original parenchymal cells, they can be classified as well differentiated or poorly differentiated tumors. Now then, what is anaplasia? Anaplasia simply means lack of differentiation. This is a hallmark of malignant tumors. So if we go back to our previous slide, well differentiated tumors will not show much anaplasia, whereas poorly differentiated tumors will show lot of anaplasia. As we can see here, poorly differentiated malignant tumors have high degree of anaplasia. So morphological alterations in neoplastic cells, what we were seeing in that photo earlier, one of the most important features of tumor cells is loss of polarity and pleomorphism. Loss of polarity simply means the orientation of the nucleus compared to the base and the apex will be changed in the cell. And pleomorphism means variation in size and shape of the tumor cells. The extent of cellular pleomorphism generally correlates with the degree of anaplasia. So you can think of it that anaplasia is a hallmark of neoplasm, right? And under the umbrella word anaplasia, we can consider all these little words: loss of polarity, pleomorphism, NC ratio, anisonucleosis. All these words collectively, all these phenomena collectively can be considered under the umbrella term of anaplasia. Okay, so NC ratio, nuclear to cytoplasmic ratio. Nuclei are enlarged disproportionately to the cell size, so that the nucleocytoplasmic ratio is increased from normal 1:5 to a 1:1. Generally, cytoplasm is 5 times more than the nucleus, but in a tumor cell, that ratio becomes 1:1. So cytoplasm area is almost equal to the nucleus area, or another way to say it is the nucleus will grow so much large that area of the nucleus will be almost comparable to area of the cytoplasm. Lastly, there is anisonucleosis, that is simply variation in size and shape of nuclei of tumor cells. So basically, variation in size and shape of cells is pleomorphism, and variation in size and shape of nuclei of tumor cell is anisonucleosis. Hyperchromatism, what is it? It is increase in the amount of nucleoprotein resulting in dark staining nuclei, referred to as hyperchromatic nuclei. Nucleolar changes, which means prominent nucleolus or nucleoli will be seen in the nucleus, reflecting increased nucleoprotein synthesis. We can also see mitotic figures and tumor giant cells. Here we have a comparative photo of a cell with normal morphology versus a cell with abnormal morphology as seen in cancer. We can see here Loss of polarity, the first topic, the first heading that we discussed. In normal cell, the nucleus has a basal polarity, that is, it is oriented towards the basement membrane away from the apex. But in tumor cell, there is loss of basal polarity. In normal cell, there is no pleomorphism. Tumor cell shows pleomorphism. In normal cell, NC ratio will be low, no anisonucleosis, normal nuclear chromatin, whereas in tumor cell, NC ratio will be high. As you can see, the nucleus is increased in size. Anisonucleosis can be seen, as you can see the various shapes of the nucleus not matching with each other, and nuclear hyperchromatism also can be made out. It will have prominent nucleoli as seen here. It will have abnormal mitotic figures. There will be tumor giant cells and also increased mucin production along with DNA aneuploidy. So here is a actual microscopic picture of such a cell. Here we can see increased nuclear to cytoplasmic ratio in this cell. Here we can see pleomorphism, that is variation in size of all these nuclei from each other. Here we can see a mitotic body. Okay, here we can see hyperchromatic nuclei. What are the various kinds of mitotic figures that we can see? Here is a bipolar mitotic figure. Here is an abnormal mitosis. And these are all various kinds of abnormal mitotic figures. Now the next two terms that we need to discuss is metaplasia and dysplasia. Metaplasia is defined as the replacement of one type of cell with another type. That means, for example, consider the case of a gastroesophageal reflux disease. In gastroesophageal reflux, there is damage of the squamous epithelium of the esophagus, leading to its replacement by glandular or gastric or intestinal epithelium more suited to an acidic environment. Why? Because they can now secrete mucus to protect themselves. So it is associated with tissue damage, repair and degeneration. Dysplasia simply means disordered growth. So a dysplastic cell exhibits considerable pleomorphism and often contains large hyperchromatic nuclei with a high nuclear to cytoplasmic ratio. The architecture of the tissue may be disorderly. At this point you might be thinking, then what is the difference between anaplasia and dysplasia? Just understand, anaplasia is when we are talking about the cell. When the cell is showing pleomorphism and anisonucleosis, we call it a anaplastic cell, that is a neoplastic cell. On the other hand, the word dysplasia generally refers to a unit of cells, to a group of cells, particularly to a particular tissue. Okay, within that tissue, if the cells are arranged in a disorderly fashion, if the architecture of the tissue is disorderly, then we call it a phenomenon of dysplasia. For example, when we consider the case of a carcinoma in situ, okay, for example, we have stratified squamous epithelium. Okay, in this case, if the various cells within all the layers of the stratified squamous epithelium, if they are showing dysplasia, that means if we see dysplastic changes involving the full thickness of the epithelium, but the lesion has not yet penetrated the basement membrane, it is considered a pre-invasive neoplasm and is referred to as a carcinoma in situ. It is still a benign one, but it is pre-malignant. That means it has the potential to show malignancy. On the other hand, an invasive carcinoma is the case where once the tumor cells breach the basement membrane, the tumor is said to be invasive. So what is local invasion? That is, what is direct spread? So benign tumors, if we consider the case of benign tumors, so they are encapsulated or circumscribed masses. Because benign tumors grow and expand slowly, they usually develop a rim of compressed fiber tissue called a capsule that separates them from the host tissue. Capsules consist largely of extracellular matrix deposited by stromal cells such as fibroblasts. Encapsulation, however, does not prevent tumor growth, only creates a tissue plane that makes the tumor discrete and readily palpable and easily accessible. For example, here is a fibroadenoma of the breast, which is a benign tumor. This encapsulated mass is sharply demarcated from the rest of the breast tissue. As you can see, this is the fibroadenoma. It has a very well demarcated capsule, and this separates it from the rest of the whiter breast tissue. Here is a microscopic view of the fibroadenoma of breast. The fibrous capsule, here we can see it on the right side, this being the fibrous capsule, limits the tumor from the surrounding tissue. On the other hand, if we consider malignant tumors, these are poorly demarcated from the surrounding normal tissue. A well-defined cleavage plane is lacking. It slowly expands, and invasion, infiltration and destruction of surrounding tissue is shown by malignant tumors, besides spread to distant sites and metastasis. So here we see a cut section of an invasive ductal carcinoma of the breast. Here we see the lesion is retracted but infiltrating the surrounding breast tissue. It is not having any well-defined border. It is locally invasive, infiltrating into the surrounding tissue. Here is a low power microscopic view. Please note the irregular infiltrative borders. These are the irregular infiltrative borders. There is no clear demarcation of the tumor mass and the normal tissue. Next to the development of metastasis, invasiveness is the most reliable feature that differentiates malignant tumors from benign tumors. Most malignant tumors do not recognize normal anatomic boundaries. Such invasiveness makes their surgical resection difficult. So next feature of malignant tumor, which is not shown by benign tumors, is a metastasis, that is the distant spread. Meta means transformation, stasis is residence. So metastasis is defined by the spread of a tumor to sites that are physically discontinuous with the primary tumor and unequivocally marks a tumor as malignant, as by definition benign neoplasms do not metastasize. It can also be defined as spread of tumor by invasion in such a way that discontinuous secondary tumor mass or masses are formed at the site of lodgement. Besides anaplasia, invasiveness and metastasis are the two other important features to distinguish malignant from benign tumors. Invasiveness of cancers permits them to penetrate into blood vessel, lymphatic, body cavity, and providing other opportunities for spread, and all malignant tumors can metastasize, with few exceptions being gliomas, basal cell carcinomas of the skin. So what are these various pathways of this spread? Metastasis will spread how? What are the pathways? The pathways are direct seeding of body cavities or surfaces, lymphatic spread, and hematogenous spread. What is lymphatic spread? In general, carcinomas metastasize by lymphatic route, while sarcomas favor the hematogenous route. That means the tumors that are arising from the epithelial tissue, they generally prefer the lymphatic route, and tumors arising from the mesenchymal tissues, they show generally metastasis by hematogenous route. And transport through lymphatics is the most common pathway for initial dissemination of carcinomas. Tumors do not contain functional lymphatics, but lymphatic vessels located at the tumor margins are apparently sufficient for the lymphatic spread of tumor cells. Sentinel lymph node is defined as the first node in a regional lymphatic basin that receives lymph flow from the primary tumor. To avoid the considerable surgical morbidity associated with a full axillary lymph node dissection of breast carcinoma, biopsy of sentinel nodes is often used to assess the presence or absence of metastatic lesions in the lymph nodes. Which means, for example, there is a tumor in the breast, and then it is also the margin of this local invasive tumor is also having a lymphatic basin in the vicinity. That means some amount of tumor cells have penetrated into the lymph nodes, also into the sentinel lymph node and other surrounding lymph nodes too. So while resecting such a tumor, in order to understand till what level the tumor has invaded, and therefore till what level we need to remove the tumor from the patient, sometimes we do biopsy of only the surrounding lymph nodes to understand which lymph node and till what level the tumor has invaded. So lymph nodes which are invaded, they will be resected away along with the rest of the tumor, and lymph nodes which are not affected, we will leave a clear margin around them. Regional nodes serve as effective barriers to further dissemination of the tumor. After arrest within the node, the cells may be destroyed by a tumor-specific immune response. Drainage of tumor cell debris or tumor antigens or both also induces reactive changes within the nodes. Thus, enlargement of lymph nodes may be caused by the spread and growth of cancer cells. Let us what we were understanding just now regarding tumor in the breast tissue. So, regional nodal metastasis. The first photo is showing us axillary lymph nodes involved by carcinoma of breast. The second photo is showing us hilar and paratracheal lymph nodes involved by bronchogenic carcinoma. The last photo, the third photo, is showing us lymphatic spread that begins by lodgement of tumor cell in the subcapsular sinus via afferent lymphatics, and it enters at the convex surface of the lymph node. Here's another photo where we see metastatic carcinoma in lymph nodes. This is a gross photo which is showing cut surface of the lymph nodes. It is showing a matted appearance, a matted mass of lymph nodes surrounded by increased fat, as we can see here. The sectioned surface shows merging capsules or lymph nodes and replacement of the usually expected gray brown tissue by large gray white areas which are only consisting of tumor cells. And in the microscopic photo also we can see masses of malignant cells which are in the subcapsular sinus and extending into the underlying nodal tissue also. These are all malignant cells which are replacing the areas of the lymphatic tissue. Lastly, we have hematogenous spread. Hematogenous spread is typical of sarcomas but is also seen with carcinomas. The most common target organs of hematogenous spread are liver, lungs, brain, bones, kidneys, and adrenals. So what are the features of hematogenous spread? As the very simple thing is when some blood vessels are lying at the margin of the tumor, some tumor cells will pass through the blood vessel. But what are its features? So systemic veins drain blood into vena cava from limbs, head, neck, and pelvis. Therefore, cancers of these sites more often metastasize to the lungs. Portal veins drain blood from the bowel, the spleen, and pancreas into the liver. Thus, tumors of these organs frequently have secondaries in the liver. Pulmonary veins provide another route of spread of not only primary lung cancer but also metastatic growths in the lungs, and therefore blood in the pulmonary veins carrying cancer cells from lungs reaches left side of the heart and then into systemic circulation, and thus may form secondary masses elsewhere in the body. Arteries with their thicker walls are less readily penetrated than are veins. Arterial spread may occur, however, when tumor passes through the pulmonary capillary beds or pulmonary arteriovenous shunts, or when pulmonary metastases themselves give rise to additional tumor emboli. Retrograde spread can also be seen by blood route and may occur at unusual sites due to retrograde spread after venous obstruction, just as with lymphatic metastasis. Grossly, blood-borne metastases in an organ appear as multiple rounded nodules of varying size scattered throughout the organ. As we can see in this photo here, we see that due to hematogenous spread, all the organs in our abdominal area which are supplied by portal circulation, cancers of those organs will show metastasis to the liver. This cut section of the liver shows lots of areas of metastasis of primary tumor. It is studded with metastatic cancer basically. Here's a microscopic view of the same. A colonic adenocarcinoma has found metastatic nodules in lung. So here is a pictorial depiction of hematogenous metastasis at common sites. Lastly, we have seeding of body cavities and surfaces. Basically, this is a transcoelomic spread. What does this mean? Through the serosal wall of the coelomic cavity, Basically, we have our coelomic cavity, that means our pleural cavity, our peritoneal cavity, all these areas. So these are having serosal wall, and tumor fragments or cluster of tumor cells break off and they get carried in the coelomic fluid and are implanted elsewhere in the body cavity. These cavities are peritoneal, pleural and pericardial cavity. And carcinomas, these are the various examples which you'll have to memorize. For example, carcinomas of the stomach seeding to both ovaries, and these are known as Krukenberg tumors. Other phenomena are carcinoma of the ovary spreading to the entire peritoneal cavity without infiltrating our underlying organs. We have other examples like pseudomyxoma peritonei and carcinoma of the bronchus and breast, which can seed to pleura and pericardium. We can also see spread along epithelium lined surfaces, for example through the fallopian tube from the endometrium to the ovaries, or vice versa. We can see spread through the bronchus into alveoli, or we can see spread through the ureters from the kidneys into lower urinary tract. We can also see spread via cerebrospinal fluid. Malignant tumors of the ependyma and leptomeninges may spread by release of tumor fragments and tumor cells into CSF. Another way of seeding is implantation by surgeon's scalpel, needles, sutures and direct prolonged contact of cancer of the lower lip, causing its implantation into the opposing upper lip. And this is the phenomenon that is rarely seen. Okay, so what are the various things we learned under seeding of body cavities and surfaces? We have transcoelomic spread, we have spread along epithelial surfaces, and spread via cerebrospinal fluid and implantation. Now the last two topics remain: mechanism and biology of invasion and metastasis, and then carcinogens. So let us understand what is the metastatic cascade. The sequence of events from the beginning of invasion to the development of metastasis constitute the metastatic cascade. It can be mainly divided into two phases, that is invasion of the extracellular matrix and then metastasis. Let us understand this concept. What is invasion of the extracellular matrix? Detachment of tumor cells from each other, followed by local degradation of the extracellular matrix and interstitial connective tissue, followed by attachment of tumor cells to new sites generated in ECM components, followed by migration of tumor cells through extracellular matrix. Let us understand by the help of this photo. If we consider this as our primary tumor, we will see detachment of tumor cells from each other, and thus they will invade the basement membrane. Therefore, we see local degradation of extracellular matrix and interstitial connective tissue. Then we see attachment of these tumor cells to these ECM components, and thus they migrate along this extracellular matrix from the area of the basement membrane to a nearby blood vessel. What happens next is steps in the metastasis. This includes intravasation of the tumor cells into the blood vessels. So how it happens? Penetration of vascular and lymphatic channels, and then it is followed by formation of tumor emboli in the blood vessel and or lymphatic circulation by interacting with host lymphocytes. There will be an arrest at a distance site within circulation. Then there will be exit from circulation, that is extravasation of tumor cells at metastatic site. And then finally there will be local growth at this metastatic site. How will there be local growth? Because there will be angiogenesis to support this metastatic tumor. Lastly, we have the carcinogenic agents. A carcinogen is an agent known or suspected to cause tumors, and such agents are said to be carcinogenic, that is cancer causing. So what is chemical carcinogenesis? Chemical carcinogenesis is basically a multi-step process in which normal cells go through multiple stages during the progression to cancer and involves many mutations. Basically, the steps involved are initiation. First, there will be a non-lethal permanent alteration or damage to the DNA of a cell by which it will get initiated. Following this, it will need to undergo promotion. What are these? This is done by promoters. What are these promoters? Promoters are agents that are non-tumorigenic and non-carcinogenic by themselves. Meaning these promoters, they cannot cause tumor by themselves. They need a cell which has already been initiated, that means already a cell which is having some DNA damage. Only then these promoters can start propagating uh, the carcinogenesis in this cell. So promoters are agents that are non-tumorigenic and non-carcinogenic by themselves and thus do not directly damage DNA. Promoters stimulate the initiated cell to enter into the cell cycle, and then there is progression. Continuous proliferation of these initiated cells leads to secondary genetic abnormalities within this tumor cell, and the tumor growth becomes autonomous. That means now it can continue in an uncoordinated and excessive manner even after cessation of the stimuli that evoke the change. Finally, the final result is development of neoplasm, which can invade and metastasize. These are the major chemical carcinogens which you will simply have to memorize. We also have radiation carcinogenesis. Radiation is a well-known carcinogen. An extremely long and latent period is common in injury by radiant energy, and it has a cumulative effect. Also, we have ultraviolet rays. UV rays are derived from the sunlight, and tumors produced by UV rays are skin cancer such as squamous cell carcinoma, basal cell carcinoma, etc. We also have microbial carcinogenesis. For example, viruses which cause tumors, and these viruses are called oncogenic viruses. Oncogenic RNA viruses are human T-cell leukemia virus type 1, and it causes adult T-cell leukemia or lymphoma in humans. We also have oncogenic DNA viruses. These include HPV, EBV, hepatitis B virus. Hepatitis B and C can lead to hepatocellular carcinoma. We also have Kaposi sarcoma herpes virus, also called human herpes virus 8. We also have Merkel cell polyoma virus causing Merkel cell carcinomas. Lastly, we have some bacterial carcinogens also. We see Helicobacter pylori bacteria. It can cause gastric adenocarcinomas and gastric lymphomas. More for you to memorize is human papilloma virus. What are the various types of HPV and the associated lesions? Similarly, for Epstein-Barr virus, these are the various cancers that can be caused by Epstein-Barr virus. So this also you'll simply have to memorize. So coming to the end of our presentation today, coming to the end of our discussion, laboratory diagnosis, how will it be done? Confirmation. Why is laboratory diagnosis necessary? Confirmation of lesion as neoplastic, it requires cytological and or histopathological examination and confirmation of the suspected organ or tissue. The different laboratory methods available for the diagnosis of malignant tumors are histopathological examination. It is based on microscopic features of neoplasm, which we have already discussed, for example pleomorphism, hyperchromatic nuclei, etc. Then we have cytological examination. This is performed on many tissues and usually done for identifying neoplastic cells. Then we have histochemistry and cytochemistry, which identify chemical nature of cell contents or their products. Then we have immunohistochemistry. It is an immunological method of identifying the antigenic component in cell by using specific antibodies. Then we have electron microscopy, which helps in the diagnosis of poorly differentiated cancers which cannot be identified by light microscopy. We also have flow cytometry, which quantitatively measures various individual cell characteristics such as membrane antigens and DNA content of tumor cells. Then we have molecular diagnosis also. These molecular techniques are used for diagnosis or predicting behavior of tumors. These are helpful in diagnosis of malignant tumors to determine the prognosis and detect minimal residual disease. Lastly, we have serum tumor markers. Tumor markers are products of malignant tumors that can be detected in the cells themselves or in blood and our body fluids. That's it for today's discussion. Thank you for your patient hearing.